The heart and the blood vessels form the cardiovascular system. CV is the transport system of the body that carries nutrients and oxygenated blood to and from the cells and removes their waste products. The heart is a muscular organ controlled by the autonomic nervous system containing 4 chambers. The main function is to pump blood around the circulatory system of the lungs and the systemic circulation of the rest of the body. Arteries and veins that carry blood throughout the body keep the heart filled with blood and maintain blood pressure. In the average day, the heart beats about 100,000 times and never rests. It must continue its cycle of contraction and relaxation in order to provide a continuous blood supply to the tissues and ensure the delivery of nutrients and oxygen and the removal of waste products. The heart is about the size of a fist, a hollow muscular organ located in the center of the thorax. The heart lies in the thoracic cavity in the mediastinum, a space between the lungs and beneath the sternum, and the rest on the diaphragm. Depending on body size and type, the heart may be positioned more upright, that is, tall bodies, or more tilted, barrel-chested bodies. The heart tilts toward the left so that 2/3 of it extends to the left of the body's midline and the rest left of the mid-sagittal plane. It has a broad superior base attached to the great vessels and a pointed apex, that is end, immediately superior to the diaphragm. The heart weighs approximately 300 grams. The weight and size of the heart are influenced by age, gender, body weight, extent of physical exercise and conditioning, and heart disease. The heart could be called the engine of life. This incredibly powerful organ works constantly, never pausing, composed of a type of muscle found nowhere else in the body. The heart works to pump blood throughout the body, delivering oxygen-rich blood to organs and tissues and returning oxygen-poor blood to the lungs. Now we'll see heart chambers. There are 4 heart chambers. The 2 upper chambers are called atria. Singular form is atrium. The 2 lower chambers are called ventricles. Right atrium receives deoxygenated blood from the body via the superior and inferior vena cava. The right ventricle receives blood from the right atrium and pumps it to the lungs via the pulmonary artery. The left atrium receives oxygenated blood from the lungs via 4 pulmonary veins. The left ventricle is the largest and most muscular chamber. It receives oxygenated blood from the lungs via the left atrium and pumps blood into the systemic circulation via the aorta. Atria serve primarily as reservoirs, receiving blood from the body or lungs. The right and left atria are separated by a common wall of myocardium called the interatrial septum. Because the atria move blood only a short distance, that is from the atria to the ventricle, they don't have to generate much force. Consequently, the walls of the atria are not very thick, it's very thin. The ventricles serve as pumps, receiving blood from the atria and then pumping it either to the lungs, that is from the right ventricle, or to the body, that is from the left ventricle. The right and left ventricles are separated by the interventricular septum. Because the ventricles pump rather than receive blood, they must generate more force than the atria. Therefore, the walls of the ventricles are thicker than those of the atria. Furthermore, because the left ventricle must generate enough force to pump blood throughout the body rather than just to the lungs, its walls are thicker than those of the right ventricle. Next is heart wall. The heart consists of 3 layers. The epicardium is the outermost layer of the heart. The epicardium, which consists of a thin layer of squamous epithelial cells, covers the heart surface, also known as the visceral layer of the serous pericardium. The epicardium is closely integrated with the myocardium. Myocardium is the middle layer and is the actual contracting muscle of the heart. It composed of a cardiac muscle and it is the thickest of the three layers and performs the work of the heart. The cardiac muscle is responsible for the contractility of the heart and therefore the pumping action. The cardiac muscle contracts with enough force and enough blood to supply the metabolic demands of the entire body. The endocardium is the innermost layer and lines the inner chambers and heart walls. At the heart's base, the serous pericardium falls back on itself to form the endocardium. It is very smooth, an important characteristic that helps keep blood from clotting as it fills the heart's chambers. The endocardium lines the heart chambers, covers the valves and continues into the vessels. It consists of a thin layer of squamous epithelial cells. The pericardium. The pericardium is a sac of connective tissue that surrounds and encloses the heart and the roots of the attached blood vessels. It consists of two parts. The outer part is the tough fibrous pericardium, while the inner part is the serous pericardium, the double layer of serous membrane forming an enclosed sac with the pericardial cavity between them. The cavity contains a small quantity of pericardial fluid that acts as a lubricant and allows the two layers to easily slide over one another with each heartbeat. Surrounding the heart is a double-walled sac called the pericardium, anchored by ligaments and tissues to surrounding structures. Pericardial sac encases and protects the heart from trauma and infection. The pericardium has two layers, the fibrous pericardium and the serous pericardium. The fibrous pericardium is a loose-fitting sac of strong connective tissue, is the outermost layer. The serous pericardium, which consists of again two layers, covers the heart surface. Parietal layer, which lines the inside of the fibrous pericardium, and the visceral layer, which covers the heart surface. Between these two layers is a pericardial cavity. This cavity contains a small amount of serous fluid which helps prevent friction as the heart beats. The pericardial space between the parietal and visceral layers holds 5 to 20 ml of pericardial fluid to lubricate the pericardial surface and cushion the heart. Now let us see the blood vessels. Arteries are vessels through which the blood passes away from the heart to various parts of the body. They convey highly oxygenated blood from the left side of the heart to the tissues. Arterioles control the blood flow into the capillaries. Capillaries allow the exchange of fluid and nutrients between the blood and the interstitial spaces. Venules receive blood from the capillary bed and move blood into the veins. Veins transport deoxygenated blood from the tissues back to the right heart and then to the lungs for oxygenation. Valves help return blood to the heart against the force of gravity. The lymphatics drain the tissues and return the tissue fluid to the blood. Attached to the heart are several large vessels that transport blood to and from the heart called great vessels. They include the superior and inferior vena cava, which is to the right atrium, pulmonary artery, which is in the left ventricle, which branches into right and left pulmonary artery. 4 pulmonary veins seen in right atrium, 2 for each lung. The aorta, which is seen in right ventricle. Now let us see valves. Valves in the heart keep blood flowing in only one direction through the heart. Think of the valves as traffic cops at the entrance to one-way streets, preventing blood from traveling the wrong way despite great pressure to do so. Healthy valves open and close as a result of pressure changes within the 4 heart chambers. First is atrioventricular valve. It is seen between atria and ventricles. Tricuspid valve on the right side of the heart and mitral valve, that is bicuspid valve, on its left side. The atrioventricular valve closes at the beginning of ventricular contraction and prevent blood from flowing back into the atria from the ventricle. These valves open when the ventricles relax. Next is semilunar valve, the pulmonary valve between the right ventricle and the pulmonary artery, and the aortic valve between the left ventricle and the aorta. The semilunar valves prevent blood from flowing back into the ventricles during relaxation. They open during ventricular contraction and close when the ventricles begin to relax. Each valve has cusps or leaflets, which are anchored to the heart wall by cords of fibrous tissue, chordae tendineae. The cusps of the valves act to maintain tight closure. The tricuspid valve has 3 cusps and the mitral valve has 2 cusps, and each of the semilunar valves has 3 cusps. A semi-rigid fibrous connective tissue called the skeleton of the heart encircles each valve. Besides offering support for the heart, the skeleton keeps the valves from stretching. It also acts as an insulating barrier between the atria and the ventricles, preventing electrical impulses from reaching the ventricles other than through a normal conduction pathway. What is cardiac conduction system? Heart's conduction system is the network of nodes, that is, a group of cells that can be either nerve or muscle tissue, specialized cells, and electrical signals that keep heart beating. 2 types of cells control heartbeat: conducting cells that carry electrical signals. Muscle cells control heart's contractions. Cardiac conduction system sends the signal to start a heartbeat. It also sends signals that tell different parts of our hearts to relax and contract, that is, to squeeze. This process of contracting and relaxing controls blood flow through heart and to the rest of the body. Now let us see the parts of the cardiac conduction system. Cardiac conduction system contains specialized cells and nodes that control heartbeat. These are the sinoatrial node, atrioventricular node, bundle of his, that is atrioventricular bundle, Purkinje fibers. SA node is sometimes called the heart's natural pacemaker. It sends the electrical impulses that start the heartbeat. The SA node is in the upper part of our heart's right atrium. It is located at the edge of our atrium near our superior vena cava, vein that brings oxygen-poor blood from our body to heart. The SA node generates electrical impulses 60 to 100 times per minute. Autonomic nervous system controls how fast or slowly SA node sends electrical signals. This part of the nervous system directs hormones that control heart rate based on what we are doing. For example, our heart rate increases during exercise and slows when we are asleep. The autonomic nervous system includes sympathetic nervous system, makes SA node work faster, which increases our heart rate. The sympathetic nervous system is having the fight or flight response. Parasympathetic nervous system is having the rest or digest response, makes SA node work slower, which decreases our heart rate. Next is AV node. AV node is located in an area known as the triangle of Coy, located between the septal leaflet of the tricuspid valve, the coronary sinus, and the membranous portion of the intra-atrial septum. This is near the central area of the heart, located in the lower aspect of the atrial septum. AV node receives electrical impulses from the SA node. If the SA node fails, the AV node can initiate and sustain a heart rate of 40 to 60 beats per minute. The atrioventricular node delays the SA node's electrical signal. It delays the signal by a consistent amount of time, a fraction of a second each time. The delay ensures that our atria are empty of blood before the contraction stops. The atria are the heart's upper chambers. They receive blood from our body and empty it into the ventricles. In order to facilitate the complete emptying of atria, the atrioventricular node delays the SA node's electrical signal. Next is bundle of His. The bundle of His is also called the atrioventricular bundle. It is a branch of fibers, nerve cells that extends from our AV node. A continuation of the AV node is the bundle of His, located at the intraventricular septum. This fiber bundle receives the electrical signal from the AV node and carries it to the Purkinje fibers. The bundle of His runs down the length of the interventricular septum, the structure that separates the right and left ventricle. The bundle of His has two branches. Left bundle branch, which extends into the left ventricle, sends signal through the Purkinje fibers to our left ventricle. Right bundle branch, which extends down the right side of the interventricular septum, sends electrical signals through the Purkinje fibers to our right ventricle. The right and left bundle branches terminate into the Purkinje fibers. Next is Purkinje fibers. Purkinje fibers are in the subendocardial surface of the ventricle walls. The subendocardial surface is the part of the endocardium, the inner layer of the tissue that lines the heart's chambers. Purkinje fibers are a diffuse network of conducting strands located beneath the ventricular endocardium. These fibers spread the wave of depolarization through the ventricles. Purkinje fibers can act as the pacemaker with a rate between 20 and 40 beats per minute if the SA and AV nodes fail. The Purkinje fibers are branches of specialized nerve cells. They send electrical signals very quickly to right and left heart ventricles. When the Purkinje fibers deliver electrical signals to ventricles, the ventricles contract. As they contract, blood flows from our right ventricle to our pulmonary arteries and from left ventricle to aorta. The aorta is the body's largest artery. It sends blood from heart to the rest of our body. Steps of the heart's conduction pathway. Heart is a pump that sends blood through our body. For each heartbeat, electrical signals travel through the conduction pathway of our heart. It starts when our sinoatrial node creates an excitation signal. This electrical signal is like electricity traveling through wires to an appliances in our home. The electrical impulse normally begins in the SA node, the pacemaker of our heart. The SA node starts the sequence by causing the atrial muscle to contract. Impulses from the SA node travel through interatrial pathways to depolarize the atria, resulting in a contraction of atria. Next, the electrical impulse travels from the atria to the AV node, that means SA node to AV node, through internodal pathways. The AV node delays the signal until our atria are empty of blood. Then the signal moves through the bundle of His down the right and left bundle branches, carrying the signal to the Purkinje fibers, causing the ventricles to contract. The ventricular conduction system delivers the impulse within 0.12 seconds. This triggers a synchronized right and left ventricular contraction and ejection of blood into the pulmonary and systemic circulations. Last, repolarization occurs when the contractile and conduction pathway cells regain their resting polarized condition. These steps make up one full contraction of heart muscle. Heart conduction system sends out thousands of signals per day to keep heart beating. The signal creates an electrical current that can be seen on a graph called an electrocardiogram or EKG. Doctors use an EKG to see how well the cardiac conduction system works. Any changes on the EKG can mean serious problems. How does electrical conduction perform with the rest of heart? The electrical signals that travel through our heart conduction system cause heart to expand and contract. These contractions control how blood flows through our heart. Ideally, the electrical conduction system keeps up a steady, even heart rate. It also helps heart speed up when we need more blood and oxygen or slow down when it is time to rest. Contractions of the heart occur in a rhythm and are regulated by impulses that normally begin at the sinoatrial node, the heart's pacemaker. The impulses are conducted from there throughout the heart. Impulses from the autonomic nervous system affect the SN node and alter its firing rate to meet the body's needs. The pumping action of the heart is accomplished by the rhythmic relaxation and contraction of the muscular walls of its two top chambers, atria, and two bottom chambers, ventricles. What is cardiac cycle? Cardiac cycle is a series of pressure changes that take place within the heart. These pressure changes result in the movement of blood through different chambers of the heart and the body as a whole. These pressure changes originate as conductive electrochemical changes within the myocardium that results in the contraction of cardiac muscles. Valves within the heart direct blood movement, which leads to organized propulsion of blood to the next chamber. There are 4 phases of cardiac cycle happen in the following order: atrial systole, atrial diastole, ventricular systole, ventricular diastole. First is atrial systole. After the SN node fires or sends signals, the atria depolarize and contract together, creating decreased volume and higher pressure in the atria than in the ventricle. The increased pressure pushes blood through the atrioventricular valves, that is, tricuspid and bicuspid valves, into the ventricle. It is important to note that the pressure of the blood due to the atria's contracting is what forces the AV valves to open. There are 3 steps to atrial systole as follows. As the atria contract, rising pressure pushes blood into the ventricles through the right and left atrioventricular valves. As atrial systole begins, the ventricles are filled to about 70% of their capacity because of passive blood flow at the end of the previous cardiac cycle. The atria contract and increasing atrial pressure provides the other 30% pushing blood through the AV valves. Therefore, the atrial systole basically fills up the ventricles to 100%. As atrial systole ends, the ventricles containing the maximum amount of blood they will hold in this cardiac cycle, which is known as the end diastolic volume or EDV. This volume is about 130 ml or 4.4 ounces in a resting adult who is standing. Next is atrial diastole. The atria after the atrial systole repolarize and relax. The elastic fibers in the walls of the atria return the atria to shape, increasing the volume and decreasing the pressure in the atria. The blood pressure in the superior and inferior vena cava on the right side of the heart and the pulmonary veins on the left side of the heart is then greater than the pressure inside the atria, so blood pushes in from these vessels to fill the right and left atria. The semilunar valves close and the atrioventricular valves open. Blood from the pulmonary veins fill the left atrium. Blood from the vena cava are also filling the right atrium. The SN node sends signals again, triggering the atria to contract. The left atrium empties its content into the left ventricle. The mitral valves prevents the oxygenated blood from flowing back into the left atrium. The right atrium empties its content into the right ventricle. The tricuspid valve prevents the deoxygenated blood from flowing back into the right atrium. Next is ventricular systole. Early in ventricular systole, the ventricles contract, but blood flow has not occurred. The pressures are not yet enough to force the semilunar valves to open or to push blood into the pulmonary or aortic trunks. At this time, the ventricles contract isometrically, generating tension and increased pressure, yet blood does not flow out. This is called isovolumetric contraction, in which all heart valves are closed. The ventricular volume does not change, but ventricular pressure is increasing. When ventricular pressure exceeds the pressure in the arterial trunks, the semilunar valves open. Blood flows into the pulmonary and aortic trunks, which is the beginning of ventricular ejection. The ventricles then contract isotonically, meaning their muscle cells shorten and there is a near constant production of tension. When a peak is reached, ventricular pressure gradually reduces near the end of ventricular systole. The right ventricle also experiences isovolumetric contraction and ventricular ejection. Yet, pressure in the right ventricle and pulmonary trunk are significantly lower. The amount of blood ejected by each ventricle during contraction, that is 70 to 80 ml of blood, is the stroke volume of the heart. At rest, this is about 60% of the end diastolic volume. This percentage is called the ejection fraction and is varied based on the different demands placed on the heart. As ventricular systole is ending, pressures in the ventricles quickly fall. Blood in the aorta and pulmonary trunk begin to flow back to the ventricles, closing the semilunar valves. When backflow starts, pressure reduces in the aorta. Once the semilunar valves are closed, pressure increases again and the elastic walls of the arteries recoil. Blood remaining in the ventricle when its semilunar valve is closed is called the end systolic volume or ESV. At rest, this volume is 50 ml, which is about 40% of the end diastolic volume. Once the conduction system has carried the electrical impulses from the AV node to the Purkinje fibers, the ventricles depolarize and contract together. Pressures in the ventricles rise to become greater than the atrial pressures, and the AV valves are forced to close. Papillary muscles also contract, pulling on the tendinous cords, chordae tendineae, to ensure that the AV valves stay closed and do not swing open toward the atria. This prevents the backflow of blood to the atria. Contraction of the ventricles decreases the volume and increases the pressure inside the ventricles. As a result, blood is pushed through the pulmonary and aortic valves into the pulmonary trunk and aorta respectively. The deoxygenated blood is pumped into the pulmonary artery. The pulmonary valve prevents the blood from flowing back into the right ventricle. The pulmonary artery carries the blood to the lungs for gas exchange. The oxygenated blood returns to the left atrium by the pulmonary veins. Oxygenated blood is pumped into the aorta. The aortic valve prevents the oxygenated blood from flowing back into the left ventricle. The aorta branches out to provide oxygenated blood to all parts of the body. The oxygen depleted blood is returned to the heart via the vena cava. Next is ventricular diastole. The ventricles then repolarize and relax. The elastic fibers in the ventricle walls return the ventricles to shape, increasing the volume and decreasing the pressures in the ventricles. The pressure inside the now full atria is greater than that inside the relaxed ventricles. So blood moves through the AV valves from the atria to the ventricle. The atria are not contracting in this phase. Blood is passively moving from the atria to the ventricle due to the difference in pressure. The pressure is also greater in the pulmonary trunk and aorta than inside the ventricles, but blood is caught in the cup-shaped semilunar pulmonary and aortic valves as it tries to return from these vessels to the ventricles. Once filled with blood, these valves are tightly closed to prevent backflow to the ventricles from the pulmonary trunk and aorta. Blood traveling passively from the atria to the ventricles in this phase reduces the pressure in the atria. So blood also moves passively from the vena cava and pulmonary veins to atria. All four chambers fill with blood during ventricular diastole. There are two steps in ventricular diastole. During this period, all heart valves are closed and the myocardium is relaxing. Ventricular pressure are still higher than that of the atria and blood cannot flow into the ventricles. This is called isovolumetric relaxation. Pressure in the ventricles drops quickly since elasticity of the heart's connective tissue and cardiac skeleton help the ventricles to re-expand toward resting dimensions. When ventricular pressure reduces to below atrial pressures, the AV valves are forced to open. Blood flows from the atria into the ventricles, meaning that all these chambers are in diastole. However, ventricular pressures continually reduce as the ventricles expand. Pressures in the ventricles are so much less than the pressure in the major veins that blood moves quickly through the relaxed atria, through the AV valves and into the ventricles. This is a passive mechanism and is the main method of ventricular filling. Before the cardiac cycle ends, the ventricles become almost 75% full. Overall, atrial systole does not contribute greatly to ventricular volume. This means that the people with severe atrial damage often survive because the blood can flow from atria to ventricles by pressure differences. However, damage to one or both ventricles can cause the heart to be unable to pump blood through the peripheral organs and tissues, because the ventricle need more pressure to pump blood to whole body. The damage to one or both ventricles are called heart failure. Circulatory routes. There are two types of circulatory routes, coronary route and systemic route. Coronary routes. The heart makes up only 0.5% of the body's weight, yet receives 5% of the body's circulatory blood. This rich blood supply is another reason the heart can stay aerobic. The heart's myocardium is not fed by the blood passing through the chambers. It has its own circulation route composed of coronary arteries and veins. We will be covering in detail in coronary circulation. Next is systemic route. These routes carry blood from the heart to tissues in the body other than the heart and back again. The simplest route goes like this: heart to arteries, to capillaries, then to veins and to heart. Example of this circulatory route: the blood leaves the heart's right ventricle to travel through the pulmonary trunk to pulmonary arteries, to arterioles, then to capillaries covering air sacs in the lungs. Oxygen is loaded to the blood within the capillaries and carbon dioxide is unloaded. From these capillaries, blood travels through venules to pulmonary veins to the left atrium of the heart. There are two types of alternative systemic routes in the body: portal routes and anastomosis. Portal routes. A portal route contains two capillary beds before blood is returned to the heart. In this type of circulation, blood travels in the following route: heart to arteries, then to capillaries, then to intervening vessels, then to capillaries, then veins, and returning to the heart. Because there are two capillary beds, this type of route allows materials to be exchanged twice between the blood and tissues before returning to the heart. Example of portal routes can be found between the hypothalamus and pituitary gland, in the kidney, and between the intestine and the liver. To better understand portal routes, take a close look at the example of the hepatic portal route between the intestine and the liver in the figure. In this route, blood travels from the heart to arteries, then to capillary beds in the small intestine and other digestive organs. Here, digested nutrients are absorbed into the blood through capillaries. Blood then travels through small veins leading to the hepatic portal vein, that is the intervening vessels, 2 capillary beds in the liver where the nutrients are processed. Blood then exits the liver via the hepatic vein on its way back to the heart. Blood travels through 2 capillary beds in this route before returning to the heart. Next is anastomosis. This type of alternative route involves vessels merging together. The 3 types of anastomosis are explained: arteriovenous anastomosis, arterial anastomosis, and venous anastomosis. Arteriovenous anastomosis is often called a shunt. It merges an artery with a vein, skipping a capillary bed. There may be a question as to why this would ever be done. After all, the point of circulation is to deliver materials to the tissues and take other waste away, and that happens in the capillaries. This type of route is used in the fingers, palms, toes, and ears in conditions of extreme cold. The capillary beds are then temporarily bypassed so that the heat is not lost. This is a protective mechanism. Arterial anastomosis form by the merging of arteries that supply the same body tissues. Such anastomosis provide collateral channels so that blood can reach these tissues. For example, if an artery is blocked by a clot or cut, a collateral channel may be able to provide required blood to the region. In the body, most organs receive blood from more than one arterial branch. What is the meaning of collateral circulation? Collateral circulation is alternate or backup blood vessels in our body that can take over when another artery or vein becomes blocked or damaged. Our collateral circulation provides alternative routes for blood flow. These routes can be found in the heart to make sure all parts of the heart are adequately fed. Arterial anastomosis develop around joints in areas where blood flow through a channel may be slowed or stopped by active movement. These anastomosis also commonly occur in the brain and abdominal organs. The arteries of the kidneys, retina, and spleen usually do not anastomose or have little collateral circulation. Blood flow interruption to these areas usually cause cellular death. Venous anastomosis. Since veins interconnect more freely than arteries, venous anastomosis are very common. It merges veins to drain an organ. Because of this, an occluded vein rarely stops blood flow or causes tissue death. Next is blood flow through the heart. The right side of the heart, made up of the right atrium and right ventricle, distribute venous blood, that is deoxygenated blood, to the lungs via the pulmonary artery, that is pulmonary circulation for oxygenation. The pulmonary artery is the only artery in the body that carries deoxygenated blood. The right atrium receives venous blood returning to the heart from the superior vena cava, that is from head, neck, and upper extremities, then inferior vena cava, that is from trunk and lower extremities, and coronary sinus, that is coronary circulation. The left side of the heart, composed of the left atrium and left ventricle, distributes oxygenated blood to the remainder of the body via the aorta, that is systemic circulation. The left atrium receives oxygenated blood from the pulmonary circulation via 4 pulmonary veins. Blood enters the right atrium of the heart from the superior and inferior vena cava. Then blood passes through the tricuspid valve to the left ventricle. Blood is forced through the pulmonary valve to the pulmonary trunk. Blood then travels through the pulmonary trunk to the pulmonary arteries, then to the lungs where carbon dioxide is unloaded and oxygen is loaded. Blood then returns to the heart from the lungs through the 4 pulmonary veins to enter the left atrium. Blood then passes through the bicuspid valve to the left ventricle, then by the force through the aortic valve to the aorta. Blood travels from the aorta to the rest of the body. Blood returns to the heart through the superior and inferior vena cava. The varying thicknesses of the atrial and ventricular walls are due to the workload required by each chamber. The myocardial layer of both atria is much thinner than that of the ventricles because there is little resistance as blood flows out of the atria and into the ventricle during diastole. In contrast, the ventricular walls are much thicker than the atrial walls. During ventricular systole, the right and left ventricles must overcome resistance to blood flow from the pulmonary and systemic circulatory system. The left ventricle is 2 to 3 times more muscular than the right ventricle. It must overcome high aortic and arterial pressures, whereas the right ventricle contracts against a low pressure system within the pulmonary arteries and capillaries. Left ventricle has to pump blood to whole body. Next is blood supply to the myocardium. The myocardium has its own blood supply that is called coronary circulation. Blood flow from aorta into the two major coronary arteries occur primarily during diastole, that is relaxation of the myocardium. The two major coronary arteries are the right coronary arteries and the left coronary arteries. The right coronary arteries and its branches supply the right atrium, right ventricle, the inferior portion of the left ventricle and the posterior septal wall and the SA node and AV node. In 90% of people, the AV node and the bundle of keys receive blood supply from the right coronary arteries. For this reason, blockage of this artery often causes serious defects in cardiac conduction. The left coronary artery divides into two main branches, the left anterior descending artery and the left circumflex artery. The left anterior descending artery supplies blood to the anterior wall of the left ventricle, the anterior ventricular septum and the apex of the left ventricles. The circumflex artery supplies blood to the left atrium and the lateral and posterior surface of the left ventricles. The divisions of coronary veins parallel the coronary arteries. Most of the blood from the coronary system drains into the coronary sinus. It empties into the right atrium near the entrance of the inferior vena cava. If you take a close look at figure below, you will see two openings within the aortic wall. The pressure of blood filling the cusp of the wall as it tries to return to the heart during ventricular diastole forces oxygen-rich blood into the right and left coronary arteries. These two arteries then branch to form the capillary beds in the heart's tissues. 20% of the blood from the capillaries is directly returned to the right atrium of the heart from small veins. The rest of the blood in the coronary circulation is collected by the great cardiac vein and the middle cardiac vein and then emptied into the coronary sinus before entering the right atrium. Next is venous return. You now understand that the pressure created by ventricular systole propels blood through the arteries and capillaries. But what causes the blood to move through the veins on its way back to the heart? There are 5 mechanisms aid in venous return. First is pressure gradient. Even though there is less pressure in the veins than in the arteries, the pressure in veins due to the action of the heart does propel blood toward the heart. Then gravity. Blood moves through veins above the heart due to the gravity and it flows downhill. Next is thoracic pump. The chest expands every time a breath is inhaled. This increases the volume and decreases the pressure within the chest. As air rushes in to equalize the pressure, blood in the veins of the abdominal cavity is sucked into the inferior vena cava of the thoracic cavity by the same principle. Next is cardiac suction. Atria return to shape during atrial diastole. This creates less pressure in the atria than in the superior and inferior vena cava and the pulmonary veins. So blood is sucked into the atria from the veins. Next is skeletal muscle pump. This mechanism is especially effective in the limbs. Skeletal muscle action massages blood through the veins, while the valves in the veins prevent backflow. As you are aware, ventricular contractions force blood out of the heart under pressure. That same pressure causes blood to continue on its journey through the arteries, capillaries, and veins as blood is returned to the heart. These are the 5 mechanisms aid in venous return. The heart rate measures the number of times per minute that the heart contracts or beats. The pulse is often confused with the heart rate but refers instead to how many times per minute the arteries expand and contract in response to the pumping action of the heart. The pulse rate is exactly equal to the heartbeat, as the contractions of the heart causes the increases in blood pressure in the arteries that lead to a noticeable pulse. Taking the pulse is therefore a direct measure of heart rate. It is important to identify whether a person's heart rate sits within the normal range. If disease or injury weakens the heart, the organs will not receive enough blood to function normally. The heart rate gets progressively slower as a person moves through childhood toward adolescence. The normal resting heart rate for adults over the age of 10 years, including older adults, is between 60 to 100 beats per minute. The resting heart rate can vary within this normal range. It will increase in response to a variety of changes including exercise, body temperature, emotional triggers, and body position, such as for a short while after standing up quickly. A person's heart rate increases during exercise as the heart beats more to pump more blood and oxygen throughout the body. However, when training for fitness, it is important not to put too much strain on the heart. While the heart rate increases as a result of physical activity, an overall decrease in target heart rate is possible over time. This is because exercise strengthens the heart muscle. Due to this, the heart can pump a great volume of blood with each heartbeat, meaning it can beat less to get the necessary nutrients and oxygen to different parts of the body, making it more efficient. A healthy heart supplies the body with just the right amount of blood at the right rate for whatever the body is doing at that time. For example, being frightened or surprised automatically releases adrenaline, a hormone, to make the heart rate faster. This prepares the body to use more oxygen and energy to escape or confront potential danger. A resting heart rate refers to the number of times the heart beats per minute when at rest. However, age, activity levels, physical fitness, and other factors can affect a person's resting heart rate. While a normal heart rate does not guarantee that a person is free of health problems, it is a useful benchmark for identifying a range of health issues. The normal resting heart rates at different ages are: for newborns 100 to 205 beats per minute, infants under 1 year 100 to 108 beats per minute, from 1 to 2 years 98 to 140 beats per minute, for 3 to 5 years 80 to 120 beats per minute, from 6 to 7 years 75 to 118 beats per minute. Older children, teens and adults 60 to 100 beats per minute. These are the normal value of heart rate. The faster the heart rate, the less time the heart has for filling. At very fast rate, the cardiac output decreases. The normal sinus heart rate is 60 to 100 beats per minute. If the person is having sinus tachycardia, the heart rate will be more than 100 beats per minute. If the person is having sinus bradycardia, the heart rate will be less than 60 beats per minute. Factors affecting heart rate. The heart generates and maintains its own beat. Even though the nervous system doesn't initiate the heartbeat, it can alter the heart's rhythm and force of contractions. Specifically, the medulla in the brain detects changes in the body and sends messages to the sympathetic or parasympathetic nervous system, that is the division of autonomic nervous system, to raise or lower the heart rate. Stimulation of sympathetic nerve fibers releases the neurotransmitter norepinephrine, producing an increased heart rate, increased conduction speed through the AV node, increased atrial and ventricular contractility, and peripheral vasoconstriction. Stimulation occurs when a decrease in pressure is detected. Stimulation of the parasympathetic nerve fibers releases the neurotransmitter acetylcholine, which decreases the heart rate and lessens atrial and ventricular contractility and conductivity. Stimulation occurs when an increase in pressure is detected. Now we'll see the heart regulation, how to regulate the heart rate. Adjusting either the heart rate or the stroke volume can change the cardiac output. Anything that changes the heart rate is called a chronotropic factor. Positive factors increase the heart rate while the negative factors decrease the heart rate. The examples: chronotropic factors of the autonomic nervous system. As mentioned before, the nervous system does not initiate the heart contractions, but it can modify their frequency. Two centers located in the middle oblongata are the cardiac accelerator center and the cardiac inhibitory center. The cardiac accelerator center uses sympathetic neurons to stimulate the SA node and AV node to speed up the heart rate. The cardiac inhibitory center uses parasympathetic neurons of the vagus nerve to keep the SA node at 70 to 80 beats per minute. If the vagus nerve is severe, the SA node will typically set the pace at 100 beats per minute. There are three types of senses that feed information to the centers in the middle oblongata are the proprioceptors, baroceptors, and chemoceptors. First one is proprioceptors. Proprioception is the body's ability to sense its location, movements, and actions. Proprioceptors in the muscles and joints signal the cardiac centers of changes in physical activity. Nerve endings are located in the body's muscles, joints, and tendons. This allows the heart to increase output even before the muscles demand more blood flow. Baroreceptors or pressoreceptors are sensors located in the carotid sinus, that is at the bifurcation of common carotid artery into external and internal carotid artery and in the aortic arc. They sense the blood pressure and relay the information to the brain so that a proper blood pressure can be maintained and detect changes in blood pressure. If blood pressure falls, the cardiac accelerator center stimulates the SA and AV nodes to increase the heart rate in an effort to restore blood pressure to homeostasis. If blood pressure falls, cardiac output drops. Therefore, the cardio-accelerator center will stimulate the heart to beat faster and maintain cardiac output. Homeostasis is the self-regulating process by which biological systems maintain stability. Vice versa, if blood pressure suddenly increases, impulses will be sent to slow the heart rate, decreasing cardiac output and lowering blood pressure. Next is chemoreceptors. Chemoreceptors are located at the aortic arc, on carotid arteries, and in the medulla oblongata. A chemoreceptor detects changes in the normal environment, such as an increase in blood levels of carbon dioxide, that is hypercapnia, or a decrease in blood levels of oxygen, that is hypoxia, and a decrease in pH, and transmit that information to the central nervous system, which engages body responses to restore homeostasis. In response, the sympathetic nervous system increases heart rate and stroke volume so as to circulate more oxygen. A cluster of chemoreceptors near the fork of the carotid artery is called a carotid body. A similar cluster in the aorta is called an aortic body. Next, we will see chemical regulation of the heart. Certain chemicals influence the heart rate. Hypoxia, acidosis, and alkalosis all depress cardiac activity. The hormones such as epinephrine and norepinephrine from the adrenal gland increases the heart rate and contractility. stress, physical activity, and excitement stimulate the adrenal gland to secrete more hormones, increasing the activity of the heart. Thyroid hormones from the thyroid gland also increase the heart rate and contractility. These hormones affect cardiac muscle fibers in much the same way as norepinephrine by the sympathetic nervous system. They increase both heart rate and contractility. Then ions. The difference in the levels of cations, that is positive ions, between the intracellular and extracellular fluid are important for the production of action potentials in the nerve and muscle fibers. For example, the concentration of potassium, sodium, and calcium have a large effect on cardiac function. Potassium ions have a negative chronotropic effect because they interfere with the repolarization of the myocardium. Increased potassium can slow the heart rate. Potassium ions are used as a part of lethal injection to stop a heart. An elevated level of sodium can decrease the heart rate and contractility. An increase in intracellular calcium levels increases heart rate and strengthens the heartbeat. On the other hand, excess sodium blocks calcium entry into the cells, thus decreasing the force of contraction, and excess potassium blocks action potential. Other factors that can affect heart rate include exercise, gender, body temperature, and age. The temperature affects several processes inside the body. When body temperature goes up, blood vessels dilate, which increases the heart rate in order to compensate for drop in blood pressure. On the other hand, a decrease in temperature can lower the heart rate, but only to some degree. If the temperature gets too low, the body will actually increase the heart rate while trying to warm up. Other factor is body fluid level. Dehydration decreases the amount of fluids in the blood, which causes constriction of coronary arteries. At the same time, the heart begins to beat faster in order to push the thicker blood through the blood vessels. Input to the cardiac center. The cardiac center in the medulla receives input from multiple sources to initiate changes in heart rate. These include receptors in the muscles, joints, arteries, and brain stem. For example, emotions and heart rate. Emotions such as fear, pain, grief, and anger all affect heart rate. This occurs because two almond-shaped areas of the brain called amygdalae are key players in the formation and storage of memories associated with emotion. It is thought that stimulation of the amygdala, such as by emotion, causes it to send impulses to the autonomic nervous system. Anxiety, fear, and anger all cause the heart to beat faster. In contrast, grief slows the heart rate. It is also interesting that just the thought of doing something frightening, such as skydiving, can make your heart beat faster. Next is stroke volume. Stroke volume is the volume of blood pumped from each ventricle of the heart with each heartbeat. The stroke volume for each ventricle is generally equal, both being approximately 70 ml in a healthy 70 kg man. It is calculated using measurements of ventricular volumes from an echocardiogram by subtracting the volume of the blood in the ventricle at the end of a beat, that is end systolic volume, from the volume of blood just prior to the next beat, that is called the end diastolic volume. The cardiac output varies whenever the heart rate or the stroke volume are altered. Regulation of stroke volume. Stroke volume is effectively the difference between the EDV and the end systolic volume. The factors that affect stroke volume are preload, force of contraction, and afterload. EDV is the amount of blood in the ventricle at the end of relaxation, and ESV is the amount of blood in the ventricle at the end of systole. Now we will see the first factor, preload. The force the cardiac muscle fibers contract with during systole is affected by the amount of stretch they are subjected to. The greater the stretch, the greater the force. This is known as the Frank-Starling law. The stretch of the cardiac muscle is directly related to the amount of blood in the ventricle at the end of diastole, which is in turn dependent on the volume of blood returned to the heart via the veins, that is venous return. Thus, venous return is related to the force of contraction of the ventricles. Anything that affects the speed or volume of venous returns affects EDV and therefore force of contraction. So, for instance, a slower heart rate allows for more time for blood to fill the ventricles, increasing the volume of blood in the ventricle at the end of diastole. Exercise increases venous return. As the increase in heart rate increases the pressure in the veins and the speed of venous return, and the effect of skeletal muscle activity squeezes the veins, pushing blood back to the heart, that is, skeletal muscle pumps. Conversely, standing still means that the venous is reduced. Thus, the people who have to stand still are taught to discreetly contract and relax their feet to aid venous return and prevent fainting. Hormonal and nervous influences. The release of adrenaline or the excitation of the sympathetic nervous system leads to the contraction of the veins and squeezing of blood back to the heart. Very fast heart rates reduce the diastolic filling time, and thus there is less time for the ventricle to receive blood before systole starts. Certain heart arrhythmias stop the atria contracting effectively, and thus atrial systole is no longer effective at pushing the last bit of blood into the ventricles. A reduced blood volume, for instance, due to a hemorrhage, reduces venous return. Next is force of contraction. Though EDV is a major component of the force of contraction because of the Frank-Starling law, force of contraction can also be affected by other factors. The contractility of the heart can be affected by several factors. Hormones such as adrenaline, glucagon, and thyroxine all increase the force of contraction. Sympathetic nervous system activity increases the force of contraction through the action of noradrenaline. Contractility can be reduced by acidemia, excess hydrogen ions in the blood, and high potassium levels in the blood. Next is afterload. Afterload refers to the pressure in the arteria leading from the ventricle, aorta, or pulmonary arteries that the ventricles must overcome in order to eject blood. In the normal adult, the pressure is 80 mmHg in the aorta and 8 mmHg in the pulmonary arteries. This difference in the pressure to be overcome is reflected in the relative thickness of the ventricular walls, with the left ventricular wall being thicker, more muscular than the right ventricle. In the average adult, aortic and pulmonary pressure is not an important factor in determining afterload as it is constant, but changes in anatomy and physiology such as hypertension or aortic wall disease can increase afterload. Increased afterload increases the amount of blood left in the ventricle after each systole, and thus also has an effect in increasing the preload, that is by increasing ventricular ESV and therefore increasing the pressure. Next is cardiac output. Cardiac output is the volume of blood ejected by the ventricles and is usually expressed in liters per minute. It is always closely matched to the body's demand for blood through the homeostatic control of the following four factors. They are heart rate, preload, afterload, and contractility. Heart rate. A faster heart rate gives more beats per minute, hence increased cardiac output. Preload. A bigger volume of blood creates more stretch and hence more force to eject a greater volume from the heart. Can increase the preload by fluids and vasopressor, and it can decrease by diuretics and vasodilation. Afterload. It is determined by the pressure and resistance within the arteries and systemic circulation. Hence, it reflects the force the heart has to push against. It can increase the afterload by vasoconstriction or decrease by vasodilation. Next is contractility. Contractility is the strength of the heart cell to shorten or contract. The mechanical properties of contracting cardiac muscle means that an increase in contractility leads to an increase in cardiac output. Calculating the cardiac output using the formula is cardiac output is equal to heart rate into stroke volume. Factors affecting cardiac output. Cardiac output is a term relating to the amount of blood the heart pumps out in a minute and is defined by cardiac output is equal to stroke volume into heart rate. Thus, the amount of blood the heart pumps out in a minute is made up of the amount of blood ejected from the ventricle in one beat times the heart rate in beats per minute. This gives a total volume. Thus, if SV is 70 ml and the heart rate is 75, then cardiac output is 70 into 75, that is 5250 ml, that is 5.25 liter per minute. So the factors affecting cardiac output is the factors regulating stroke volume and the factors regulating the heart rate. Heart sounds refer to the noises that occur when blood flows through the heart chambers as valves open and close during the cardiac cycle. So the sound which we are hearing is because of the valves opening and closing. The heart has 4 chambers. They are the right atrium, the right ventricle, the left atrium and the left ventricle. Valves at the bottom of each atrium empty into the 2 ventricles. There are 2 phases in the cardiac cycle, systole and diastole. You can watch my cardiovascular part 3 video to know more about cardiac cycle. You will get the link in description. The systole is when the ventricles contract and pump blood out, and the diastole is when the ventricles relax and fill the blood. These 2 phases make up the heartbeat. The individual is not usually conscious of his heartbeat, but if the ear or the diaphragm or the stethoscope is placed on the chest wall, a little below the left nipple and slightly near the midline, the heartbeat can be heard. A heartbeat makes a characteristic double thumping sound when heard through a stethoscope because of vibrations of the heart tissues related to the valve closing. The cardiac cycle features 4 sounds. It is much easier to hear the first 2 noises, that is lub and dub, which are high-pitched. The third and fourth sounds are low-pitched and often quieter. Sometimes if the doctor can hear the third and fourth sounds, it may indicate a potential problem with heart function. The most fundamental heart sounds are the first and 2 sounds, usually abbreviated as S1 and S2. 2 sounds separated by a short pause can be clearly distinguished. They are described in words as lub, dub. Now let us see first sound. The first thumping sound, lub, occurs during ventricular contraction when the AV valves close and indicates when ventricular pressure rises above the atrial pressure. These valves close to prevent blood from flowing into either atrium after the 2 ventricles contract to pump blood into the pulmonary artery and aorta. This is the beginning of ventricular systole. The first sound is usually the loudest, longest and most resonant heart sound. Vibrations from closing the 2 valves known as the mitral and tricuspid valves causes the first lub heart sound. As the valve closes, this creates an audible vibration as the first heart sound. As the valve closes almost simultaneously, it usually creates a single sound. Clinically, this noise corresponds to the pulse and refer to it as S1. S1 is caused by closure of the mitral and tricuspid valves at the beginning of isovolumetric ventricular contraction. S1 is normally slightly split, that is 0.04 second, because mitral valve closure precedes tricuspid valve closure. However, this very short time interval cannot normally be heard with a stethoscope, so only a single sound is perceived. A split S1 occurs when the time difference between the two valves increases. Split heart sounds may indicate a problem in the heart. Next we will see second sound. The second sound, dub, occurs when the ventricles relax to receive blood from the atria after pumping blood, which is the diastole phase of the cardiac cycle. The pulmonary and aortic or semilunar valves close, which causes vibrations and results in the second dub sound. This is the beginning of ventricular relaxation or diastole. The sound is shorter and sharper than the first sound. The two heart sounds are often described as lub, dub, pause, lub, dub, pause, and so on. If the aortic valve closes before the pulmonic valve, it may cause two distinct sounds, which experts may refer to as aortic and pulmonic components. The pulmonic valve may close after the aortic, as the right ventricle can fill with more blood, leading to a slightly longer ejection time. S2 is produced by the closure of the aortic and pulmonic valves at the beginning of isovolumetric ventricular relaxation, and the sound is physiologically split because aortic valve closure normally precedes pulmonic valve closure. This splitting is not of fixed duration. The timing of S2 splitting changes depending on the phase of respiration, body posture, and certain pathological conditions. The first heart sound is heard as the atrioventricular valve, that is tricuspid and mitral valve close. This sounds like lub of lub dub. The second heart sound is heard when the semilunar valves close and is loudest at the base of the heart, that is aortic and pulmonic valves. This sounds like dub of lub dub. S1 split is heard when tricuspid and mitral valves closing asynchronously. S2 split is heard when aortic and pulmonic valves closing asynchronously. Now let us see the third sound. The third heart sound, that is S3, when audible, occurs early in ventricular filling and may represent tensing of the chordae tendineae and the atrioventricular ring, which is the connective tissue supporting the AV valve leaflets. This sound is normal in children, but when heard in adults, it is often associated with the ventricular dilation, as occurs in systolic ventricular failure. A third heart sound may be heard if ventricular wall compliance is decreased and structures in the ventricular wall vibrates. This can occur in conditions such as heart failure or valvular regurgitation. Valvular regurgitation is a condition in which one of the heart valve does not close properly, causing blood to flow backward through the valve. The third sound is low-pitched when blood rushes into the relaxing ventricle after the opening of the atrioventricular valve. The rush of blood may be audible. Although the sound is standard in some people, including children and young adults, in others it can signal disease such as congestive heart failure. The third sound may be abnormally audible as a ventricular or protodiastolic gallop, which describes a galloping sound. Now we will see fourth sound. The fourth heart sound may be heard on atrial systole if resistance to ventricular filling is present. The fourth heart sound, when audible, is caused by the vibration of the ventricular wall during atrial contraction. This sound is usually associated with stiff ventricle and therefore is present in patients with ventricular hypertrophy, myocardial ischemia, or in older adults. The fourth heart sound is also low-pitched and very quiet. When present, this sound typically occurs due to the atrium contracting against a stiff ventricle. Some doctors may refer to the fourth sound as an atrial gallop. This sound often suggests the presence of cardiac disease, typically involving a decrease in ventricular compliance and resistance to filling. This may include conditions such as hypertension, aortic stenosis, cardiomyopathy. The four sounds are briefly mentioned in this table. The mitral valve closes just before the tricuspid valve. Also, the aortic semilunar valve usually closes just before the pulmonic valve. Auscultating the four specific regions of the thorax distinguishes each individual valve sound. The 4 points are not directly superficial to the valves because the sounds take various paths to reach the chest wall. However, these points help to define the four corners of a normal heart. By understanding a normal heart's location and size, one can more easily recognize a disease and or an enlarged heart. The 4 points of auscultation used to hear each individual valve sound as are follows. Aortic valve. It is heard in the second intercostal space at the right sternal margin, found right of the sternal border in the second intercostal space, represents S2 sound, that is dub. Pulmonary valve. It is in the second intercostal space at the left sternal margin, found left of the sternal border in the second intercostal space, represents S2, that is dub. As we know, aortic valve and pulmonary valve closure is caused S2 sound, that is dub sound. Mitral valve. It is over the heart apex in the fifth intercostal space, in line with the middle of the clavicle, found left of the sternal border at the mid-clavicular in the fifth intercostal space, represents S1 sound, that is lub. Also the site of point of maximal impulse. Next is tricuspid valve. Usually heard in the right sternal margin of the fifth intercostal space, found left of the sternal border in the fourth intercostal space, represents S1 sound, that is lub. So as we know, the mitral valve and tricuspid valve closure causes the S1 sound, that is lub sound. Ear's point. Found left of the sternal border in the third intercostal space. The ear's point is a crucial auscultation location for healthcare professionals to listen to the heart sounds and detect any heart murmurs. The base of the heart includes the aortic and pulmonic areas, and S2 will be loudest at the base. Aortic and pulmonic murmurs are heard best at the base, with the patient leaning forward and sitting up with the diaphragm of the stethoscope. The apex of the heart includes the tricuspid and mitral areas, and S1 will be loudest at the apex. S3 and S4, along with mitral stenosis, that is a narrowing of mitral valve, murmurs will be heard best at this position, with the patient lying on their left side with the bell of the stethoscope. Patient positioning for heart auscultation. The patient can be on supine or sitting up. Use the diaphragm and listen at all 5 auscultation sites, noting S1 and S2, and if there are any splits present. In addition, distinguish S1 from S2. Then repeat with the bell of the stethoscope, noting any other extra sound. We have to make the patient lie down on left side. Turn the patient onto their left side and auscultate with the bell of the stethoscope at the apex area and listen for S3, S4 and mitral stenosis murmurs. Listen with the diaphragm at the aortic and pulmonic sides for murmurs when patient sit up, lean forward and ask the patient to exhale. How to distinguish S1 from S2? This is complicated when first starting out with the heart auscultation, but it's vitally important so you can assess extra heart sounds. S1 is louder at the apex. Feel on the carotid artery while listening at the apex. S1 correlates with the carotid pulsation. In EKG monitor, if the patient is on a bedside monitor, the R wave of the QRS complex will correlate with the sound of S1. Basics about S3, S4 and heart murmurs. S3 and S4 are heard best at the apex of the heart with the bell of the stethoscope while the patient is on their left side. It is normal for a patient not to have a S3, S4 or heart murmur. S3 is heard after S2 and sounds like lub dub ta. It is caused by vibrations of ventricle filling from a resistant ventricle due to fluid volume overload or heart failure. S4 is heard before S1 and sounds like ta lub dub. It is caused by ventricular resistance from an atrial kick during presystole, that is hypertrophic left ventricle. Heart murmurs is blowing or swishing noise from blood turbulence in the chambers of the heart due to valve defect or valve problem, that is stenosis or regurgitation. Grading the heart murmurs. Grade 1, hard to hear the sound. Grade 2, it is faint but heard. Grade 3, easily to hear. Grade 4, loud with a chest thrill. Grade 5, it is very loud, can hear when corner of the chest piece is lifted off the chest. Grade 6, it is loudest, can hear when whole chest piece lifted off the chest. Causes of this abnormal finding include cardiac hypertrophy, disease, or injury to the ventricular wall. How to test heart sounds? A doctor will listen to the heart using a stethoscope called auscultating. A stethoscope has a chest piece with two attachments called a bell and a diaphragm, which connect via a tube to two earpieces. A doctor can use the diaphragm attachment to hear high-pitched noises such as the first and second heart sounds. They can then use the bell attachment to listen for low-pitched sounds such as third and fourth heart sounds. In some cases, an amplified stethoscope may be necessary to hear the third and fourth sounds. The doctor may listen to different areas of the heart, including the base, between the bottom left of the heart and the sternum, the apex, which is at the bottom left of the heart, the aortic and pulmonary areas to the left and right of the sternum. Aside from the four heart sounds, a doctor may hear abnormal sounds or murmurs which could indicate heart problems. A heart murmur is not one of the four heart sounds. A murmur may sound like a rasping or oozing noise due to a turbulent flow of blood through the heart walls. A heart murmur may be harmless, known as an innocent heart murmur. This type of murmur does not usually cause symptoms, and doctors do not consider them serious. Other heart murmurs could indicate a problem in the heart. These murmurs can result from problems with heart valves such as aortic stenosis and aortic regurgitation. Medical professionals grade murmurs on a scale according to their loudness. They will also categorize the murmur as systolic or diastolic, depending on the stage of the heartbeat. Some heart murmurs may be continuous, meaning a doctor can hear them during both the systole and diastole. The doctor may also perform tests to check a person's heart function with a murmur. These may include an electrocardiogram, an echocardiogram, and a chest X-ray. When a stethoscope is placed on the chest over different regions of the heart, four basic heart sounds can be heard. That is, listening to the heart sound is called cardiac auscultation. The sound waves responsible for heart sounds, including abnormal sounds such as murmurs, are generated by vibrations induced by valve closure, abnormal valve opening, vibrations in the ventricular chambers, tensing of the chordae tendineae, and by turbulent or abnormal blood flow across valves or between cardiac chambers. Murmurs can be divided into two general classifications related to origin: those caused by valve defects and those caused by interchamber defects that permit an abnormal flow of blood between cardiac chambers. Blood pressure. Blood pressure is the pressure exerted by blood within the blood vessels. The pressure is at its greatest near the heart but decreases as the blood moves away from the heart. Blood pressure helps us to know the workings of the heart and the vessels of the body. BP is controlled by a variety of complex physiological mechanisms which allow both short-term adaptation and long-term maintenance of BP within a normal range. Blood pressure which is too high or too low can lead to a wide range of pathology. It can cause ruptured blood vessels, reduced perfusion to organs, and therefore the mechanisms which maintain BP homeostasis need to be healthy. Blood flow is the amount of blood flowing to an area in a given amount of time, and it is usually expressed in milliliters per minute. Blood pressure is the force of the blood against the blood vessel wall, and it is dependent on three things, that is cardiac output, blood volume, and blood resistance. Cardiac output is a factor because it takes into the account the force of ventricular contractions. The blood pressure changes in response to changes in cardiac output. If the cardiac output increases, blood pressure also increases. If the cardiac output decreases, the blood pressure also decreases. If either the stroke volume or the heart rate increases, the cardiac output increases, and as a result, the blood pressure also increases. If the stroke volume or the heart rate decreases, the cardiac output and the blood pressure decreases. The volume of blood pumped out from the ventricle with each contraction is called the stroke volume, and it equals about 70 ml for an adult at rest. The volume of blood that is present in the body affects blood pressure. An increase in blood volume in the body increases the rate of blood flow to the heart, resulting in increased cardiac output. Blood volume makes a difference because more blood exerts a greater force on the blood vessel walls. Now let us see the factors which cause fluctuation in blood pressure. Physiological factors. Many factors influence arterial blood pressure, which may be affected by other factors such as age, gender, hormones, disease, and exercise, etc. Peripheral resistance is another physiological factor. In the circulatory system, this is the resistance of the blood vessel. The higher the resistance, the higher the arterial pressure upstream from the resistance to blood flow. Resistance is related to vessel radius, vessel length, blood viscosity, and smoothness of the blood vessel walls. Blood viscosity. Viscosity means the thickness and stiffness of blood. The amount of albumins and red blood cells determine the thickness of blood. Thicker blood offers more resistance to flow and requires more pressure to get into move. An increase in viscosity of the blood increases blood pressure. The resistance is provided by plasma proteins and other substances in the blood. Next, vessel length. The greater the vessel length, the more friction occurs between the blood and the vessel walls. Friction slows the blood flow. Vessel length becomes a factor in people who are obese. More pressure is needed to propel blood through their longer system of vessels to feed their increased tissue mass. Next is vessel radius. The larger the radius, the lower the resistance. Vessel radius becomes a factor because the smaller the radius, the more blood comes in contact with the walls of the vessel. Vessel radius can be controlled through vasoconstriction and vasodilation in several different ways to regulate blood pressure. Blood pressure can be measured in a number of different ways, with the most common being systolic and diastolic blood pressure. Systolic blood pressure represents the pressure in the blood vessels when the heart contracts. Diastolic blood pressure represents the pressure in the blood vessels between heartbeats, that is, when it is relaxed. Mean arterial blood pressure is another method of assessing blood pressure. Mean arterial blood pressure is equal to cardiac output into systemic vascular resistance. Mean arterial blood pressure can be calculated from the systolic blood pressure and diastolic blood pressure using the following formula. Mean arterial blood pressure is equal to diastolic blood pressure plus pulse pressure divided by 3. Pulse pressure is calculated by subtracting diastolic blood pressure from systolic blood pressure. Now let us see how our body is controlling BP. The BP is regulated by many factors such as neuronal regulation, that is through autonomic nervous system. Autoregulation, that is through the renin-angiotensin-aldosterone system. Then baroreceptase, chemoreceptase, hypothalamus, and circulating hormones. Circulating hormones are adrenaline, noradrenaline, and renin are the main examples of circulatory hormones. Baroreceptor reflex is a neurally mediated reflex that regulates blood pressure in the short term. This reflex is crucial for maintaining blood pressure throughout the day, and in its absence, even a slight change in posture could lead to significant change in the blood pressure. There are mechanoreceptors known as baroreceptors located in the aortic arc and at the bifurcation of common carotid artery into external and internal carotids, which constantly monitor the mean arterial blood pressure and pulse pressure, and they are sensitive to pressure changes within the blood vessel. They sense the blood pressure and relay the information to the brain so that a proper blood pressure can be maintained and detect changes in blood pressure. Increases in arterial pressure stimulate baroreceptors and the heart rate and arterial pressure decrease. Decreases in arterial pressure reduce stimulation of the baroreceptors and vasoconstriction occurs, as does an increase in heart rate. When the blood pressure increases, signals are sent to cardioregulatory center in the brainstem. Increases in arterial pressure result in increased baroreceptor activity, increase in the firing rate in the associated afferent neurons carrying this information to the cardiovascular center in the medulla. In response to this, the parasympathetic nervous system activity increases and the sympathetic nervous system activity decreases. The net effect is reduced heart rate and systemic vasodilation, collectively reducing mean arterial blood pressure. On the other hand, if the blood pressure decreases, there is less baroreceptor activation, meaning the impulse rate of the afferent fibers decreases, causing the cardiovascular center to increase sympathetic nervous system outflow and decrease parasympathetic nervous system outflow. The cardioregulatory center increases the sympathetic activity to the heart and the blood vessels, thus increasing heart rate and vasoconstriction, resulting in increased blood pressure. The net effect of this is increased cardiac contractility, increased heart rate, and increased systemic vasoconstriction, causing an overall increase in blood pressure. Next is chemoreceptors. Chemoreceptors are found close to the carotid and aortic baroreceptors in small structures called carotid bodies and aortic bodies. They are sensitive to any change in the chemical composition of the blood, such as a decrease in oxygen level and pH of the blood or an increase in the carbon dioxide level. These receptors send impulses to the cardiovascular center, which in turn increase the sympathetic stimulation to the blood vessels, causing an increase in blood pressure. Chemoreceptors also stimulate the respiratory centers in the brain to increase the rate of respiration. Next is hypothalamus. The hypothalamus responds to stimuli such as emotion, pain, anger, and it stimulates sympathetic nervous system activity, affecting blood pressure. Next is stretch receptors. It is located in the vena cava and the right atrium, respond to pressure changes that affect circulatory blood volume. When the BP decreases as a result of hypovolemia, a sympathetic response occurs, causing an increased heart rate and blood vessel constriction. When the BP increases as a result of hypervolemia, an opposite effect occurs. Specialized stretch receptors responding to pressure at key places within the cardiovascular system provides the brain with information regarding moment-to-moment changes in arterial blood pressure, that is aortic and carotid baroreceptors, or venous blood volume, that is cardiopulmonary baroreceptors. This afferent input controls a variety of reflex responses encompassing autonomic, endocrine, and behavioral adjustments, each geared toward maintaining cardiovascular homeostasis. Key among these reflexes is the adjustment of autonomic outflow and the central neural pathways. Next is circulating hormones. Hormones such as antidiuretic hormones and atrial natriuretic peptide hormones help to regulate circulating blood volume by fluid and electrolyte regulation, thus affecting blood pressure. It is released when the body is dehydrated and causes the kidneys to conserve water, thus concentrating the urine and reducing its volume. At high concentrations, it also raises blood pressure by inducing moderate vasoconstriction. Atrial natriuretic peptide. ANP is a powerful vasodilator and a protein hormone secreted by heart muscle cells. It is released by the atria of the heart. ANP is a vasoactive peptide released in response to a rise in atrial pressures, which in turn are linked to venous pressure. ANP lowers blood pressure primarily by vasodilation and the inhibition of sodium reabsorption by the kidney, the latter having a diuretic effect. This system increases sodium excretion in part through the opposition of the renin-angiotensin-aldosterone system, inhibiting renin and aldosterone release. ANP has also been shown to have inhibitory effects on vasopressin. ANP acts to reduce the water, sodium, and adipose levels in the circulatory system, thereby reducing blood pressure. Next is renin-angiotensin-aldosterone system, or RAS. RAS is an essential component of blood pressure regulation that acts to increase blood volume and increase systemic vascular resistance. Renin, a potent vasoconstrictor, causes the BP to increase. When blood volume is low, juxtaglomerular cells in the kidneys secrete renin directly into circulation. Plasma renin then carries out the conversion of angiotensinogen released by the liver to angiotensin 1. Angiotensin 1 is subsequently converted to angiotensin 2 by the angiotensin converting enzyme found in the lungs. Angiotensin 2 stimulates the release of aldosterone, which promotes water and sodium retention by the kidneys. This action increases blood volume and BP. Angiotensin 2 is also capable of increasing plasma volume through the stimulation of thirst and antidiuretic hormone, another regulator of blood pressure, which will be discussed shortly. Aldosterone acts on the principal cell found in the DCT, that is distal convoluted tubule, and collecting duct of the nephron, increasing sodium reabsorption while simultaneously increasing potassium secretion into the tubules. Aldosterone is having the ability to increase the volume of the extracellular fluid compartment and thus BP. Several common antihypertensive medications aim to decrease blood pressure through inhibition of aldosterone formation. Next is antidiuretic hormone. Antidiuretic hormone, also known as vasopressin, is involved in the control of blood pressure. Antidiuretic hormone is made by cell bodies located in the hypothalamus and released from the adjacent posterior pituitary gland. Antidiuretic hormone influences BP indirectly by regulating vascular volume. Increases in blood volume result in decreased antidiuretic hormone release, increase in diuresis, decreasing blood volume and thus decreasing BP. Decreases in blood volume result in increased antidiuretic hormone release. This promotes an increase in blood volume and therefore increase in BP. ADH increases water reabsorption by binding to V2 receptors. When someone becomes dehydrated, the osmolarity of the extracellular fluid increases, leading to ADH release from the pituitary gland, that is posterior pituitary gland. Water is then reabsorbed at an increased rate at the level of the kidney, ultimately acting to increase the intravascular fluid volume. This increases blood pressure through an increase in venous pressure, thereby boosting venous return to the heart and increasing cardiac output. ADH also acts as a vasoconstrictor, targeting V1 receptors on vascular smooth muscle at high concentrations, such as in response to hemorrhagic shock. Next is how to take blood pressure. Blood pressure is measured using a sphygmomanometer. It can be electronic, digital, or aneroids. And it is a non-invasive method of monitoring a patient's blood pressure. It may be used as a diagnostic test on patients with arterial blood pressure problems. It can be recorded with the patient sitting comfortably in a chair or lying in bed. Ambulatory blood pressure monitoring is also sometimes used to check how well medicine used to treat hypertension is working. Ambulatory blood pressure monitoring is a method to measure your blood pressure on a continuous basis for 24 hours. Blood pressure is usually measured in the brachial artery by using a sphygmomanometer that has a pressure cuff and a device to inflate the cuff. The original instruments, that is a sphygmomanometer, measured blood pressure as the amount of pressure necessary to lift a column of mercury a certain distance. So the units for blood pressure are millimeters of mercury. Newer sphygmomanometers typically use a dial to indicate pressure using the same units. Two pressures are recorded and expressed as systolic pressure and diastolic pressure. For example, a normal blood pressure for a 20 to 30-year-old is 120 by 72 mmHg. The systolic pressure created in the brachial artery during ventricular systole is 120 mmHg. The diastolic pressure created in the brachial artery during ventricular diastole is 72 mmHg. Electrocardiogram. An electrocardiogram is used to record electrical changes in the myocardium during the cardiac cycle using a machine known as an electrocardiograph. An ECG provides information about coronary circulation. The electrical impulse that travels through the heart can be viewed by means of electrocardiography, the end product of which is an electrocardiogram. Each phase of the cardiac cycle is reflected by specific waveforms on the screen of a cardiac monitor or on a strip of ECG graph paper. A rhythm is defined as 3 consecutive heartbeats displaying identical waveforms on the ECG. The similarity of the waveforms indicates that their origin is the same. The sinoatrial node is the heart's pacemaker under normal circumstances, and the rhythm is referred to as sinus rhythm. Print a copy of rhythms from one or more specific ECG leads over a set time called a rhythm strip. An action potentials stimulate cardiac muscle fiber contraction. A specific pattern appears. It is not the same as individual action potentials because body fluids conduct electrical currents. These electrical changes can be detected on the body surfaces. Ventricular rhythm exists if 3 or more consecutive beats have a ventricular origin. Now let us see how to obtain an electrocardiogram. An ECG is obtained by placing electrodes on the body at specific areas. Biomonitoring electrodes comes in various shapes and sizes but all have 2 components. An adhesive substance that attaches to the skin to secure the electrodes in place. A substance that reduces the skin's electrical impedance, facilitating the transfer of ions from the tissue to electrons in the electrode, enhancing the conductivity. Now let us see how to apply the electrodes. Gently abrading the skin with a clean, dry gauze pad helps to expose the inner conductive layer of epidermis, which will reduce skin impedance. Although cleansing the skin with alcohol removes any oily residue from the skin, it also increases the skin's electrical impedance and hinders detection of the cardiac electrical signal. If the amount of chest hair prevents the electrode from having good contact with the skin, the hair may need to be clipped. Poor electrode adhesion will cause distorted, irrelevant and extraneous ECG waveforms which may distort capturing an accurate ECG waveform. The monitoring system requires an adequate electrical signal to analyze the patient's cardiac rhythm. When applying electrodes, the recommendations should be followed to optimize skin adherence and conduction of the heart's electrical current. The recommendations are: wash the skin surface of dead cells with soap and water. Dry well using a washcloth or gauze. Clip hair from around the electrode site if needed. Do not shave. Connect the electrodes to the lead wires prior to placing them on the chest. Connecting lead wires when electrodes are in place may be uncomfortable for some patients. Peel the backing of the electrode and check to make sure the center is moist with electrode gel. Locate the appropriate lead placement and apply the electrode to the skin, securing it in place with light pressure. Change the electrodes every 24 hours. Examine the skin for irritation and apply the electrodes to different locations. If the patient is sensitive to the electrodes, use hypoallergenic electrodes. The number and placement site of the electrodes depend on the type of ECG being obtained. Most continuous monitors use 2 to 5 electrodes, usually placed on the limbs and the chest. These electrodes create an imaginary line called a lead, which serves as a reference point from which the electrical activity is viewed. A lead is like an eye of a camera. It has a narrow peripheral field of vision, looking only at the electrical activity directly in front of it. Therefore, the ECG waveforms that appear on the ECG paper and cardiac monitor represent the electrical impulse in relation to the lead. A change in the waveform can be caused by a change in the electrical impulse, where it originates or how it is conducted, or by a change in the lead. Electrodes are the adhesive conductive part that sticks to the skin. Lead wires are the color-coded wire that connects to the electrode and transmits electrical activity to the ECG machine. The electrodes are attached to cable wires which are connected to one of the following: an ECG machine placed at the patient's side for an immediate recording, that is a standard 12-lead ECG. A cardiac monitor at the patient's bedside for continuous reading. This kind of monitoring, usually called hardware monitoring, is used in intensive care units. A small box that the patient carries and that continuously transmits the ECG information by radio waves to a central monitor located elsewhere called telemetry. The primary benefit of using telemetry is that the system is wireless, which allows patients to ambulate while 1 or 2 ECG leads are monitored. The patient has electrodes placed on the chest with a lead cable that connects to the transmitter. The transmitter can be placed in a disposable pouch and worn around the neck, or simply secured to the patient's clothing. Most transmitter batteries are changed every 24 to 48 hours. A small lightweight tape recorder-like machine called ambulatory ECG monitoring, or a Holter monitor, that the patient wears and that continuously records the ECG, which is later viewed and analyzed with a scanner. Ambulatory electrocardiography. Ambulatory electrocardiography is a form of continuous or intermittent ECG home monitoring. It is used to identify the etiology of syncope or palpitation caused by dysarrhythmias, detect episodes of myocardial ischemia, evaluate effectiveness of treatment of heart failure and dysarrhythmias, as well as evaluate the functioning of ICDs and pacemakers. Several types of devices are available and are worn either externally or implanted under the skin. The ECG is transmitted to a centralized monitoring station via telephone. Newer devices transmit ECGs through the use of wireless technology to a secure website. ICD means it is an implantable cardioverter defibrillator, a small battery-powered device placed in the chest that detects and stops irregular heartbeats, also called arrhythmias. It continuously checks the heartbeat and delivers electric shocks when needed to restore a regular heart rhythm. Next is continuous monitors, commonly called Holter monitors. These small portable recorders are connected to chest electrodes that record the ECG using several leads onto a digital memory devices. The number varies based on model used. The patient wears the recorder for 24 to 48 hours and in certain cases up to 2 weeks. If the patient experiences symptoms, they are instructed to activate the event marker. The patient is also asked to keep a diary to note the date and time of symptoms or performance of unusual activities. The diary is used by the primary provider to correlate symptoms with detected dysarrhythmias. Once monitoring is completed, the patient returns the device to the primary provider's office. Data from the digital memory device are then uploaded into a computer for analysis, and rhythms that need further evaluation by the primary provider are identified. The effectiveness of this form of monitoring is dependent upon the patient's adherence with keeping a diary and marking events. The placement of electrodes for monitoring varies with the type of technology, the purpose of monitoring, and the standards of the healthcare facility. For a standard 12-lead ECG, 10 electrodes, 6 on the chest and 4 on the limbs, are placed on the body. To prevent interference from the electrical activity of skeletal muscle, the limb electrodes are placed on areas that are not bony and that do not have significant movement. Now let us see where to place an electrode in continuous electrographic monitoring. Standard 3-wire lead placement. Place the white electrode just below the patient's right clavicle. Place the black electrode below the patient's left clavicle near the shoulder. Place the red electrode below the patient's left pectoral muscle near the apex of the heart. Standard 5-wire lead placement. Place white, black and red electrodes in same position as 3-lead electrode. Place green electrode opposite the red electrode. Place brown precordial electrode to the right of the sternum border in the 4th intercostal space. Now let us see chest electrodes and placement. V1. V1 is placed on 4th intercostal space on the right sternum. V2 is placed on 4th intercostal space at the left sternum. We will skip right now V3. V4 is placed 5th intercostal space at the mid-clavicular line. V3 is placed midway between placement of V2 and V4. V5 is placed on anterior axillary line on the same horizontal level as V4. V6 is on mid-axillary line on the same horizontal level as V4 and V5. Now let us see where to place the limb electrodes. RA, that is to right arm, anywhere between the right shoulder and right elbow. RL, that is to the right leg, anywhere below the right torso and above the right ankle. LA, that is to left arm, anywhere between the left shoulder and the left elbow. LL, left leg, anywhere below the left torso and above the left ankle. When we place the electrode, it should be symmetrical. Now we'll see modified 12-lead ECG placement. Placing the limb electrodes and lead wires on the torso instead of the extremities. Placing limb electrodes on the torso may be necessary for an amputated extremity, infants to reduce motion, and the patient who is having excessive limb movement. It is important to note studies have suggested potentially significant changes to the ECG morphology when the limb electrodes are placed on the torso. As a result, if the limb electrodes are placed on the torso, then it is good practice to notify the provider and write torso positioned limbs on the ECG. There are 3 sets of leads. Standard limb or bipolar leads, that is lead 1, lead 2, lead 3, utilizes 3 electrodes. These leads form a triangle known as Einthoven triangle. Next is augmented unipolar limb leads, AVR, AVL, AVF. Then precordial unipolar leads, that is V1, V2, V3, V4, V5 and V6. Now we'll see the relationship of electrocardiographic complex lead system and electrical impulse. The heart conducts electrical activity which the ECG measures and shows. The configurations of electrical activity displayed on the ECG vary depending on the lead or view of the ECG and on the rhythm of the heart. Therefore, the configuration of a normal rhythm tracing from lead 1 will differ from the configuration of a normal rhythm tracing from lead 2. Lead 2 will differ from lead 3 and so on. The same is true for abnormal rhythms and cardiac disorders. To make an accurate assessment of the heart's electrical activity or to identify where, when and what abnormalities occur, the ECG needs to be evaluated from every lead, not just from lead 2. Now let us see components of electrocardiogram. The ECG waveform reflects the function of the heart's conduction system in relation to the specific lead. The ECG offers important information about the electrical activity of the heart and is useful in diagnosing dysarrhythmias. ECG waveforms are printed on graph paper that is divided by vertical and horizontal lines at standard intervals. Time and rate are measured on the horizontal axis of the graph and amplitude or voltage is measured on the vertical axis. The electrical events of the heart, that is ECG, are usually recorded as a pattern of a baseline, that is isoelectric line, broken by a P wave, a QRS complex and a T wave. In addition to the wave components of the ECG, there are intervals and segments. The isoelectric line is a point of departure of the electrical activity of depolarizations and repolarizations of the cardiac cycles and indicates periods when the ECG electrodes did not detect electrical activity. An interval is a time measurement that includes waves and or complexes. A segment is a time measurement that does not include waves and or complexes. When an ECG waveform moves toward the top of the paper, it is called a positive deflection. When it moves toward the bottom of the paper, it is called a negative deflection. When reviewing an ECG, each waveform should be examined and compared with the others. Nodes are placed on the skin and connected by wires to the electrocardiograph. Typically, tall leads or electrodes are used that respond to weak electrical changes by moving a pen or stylus on a moving strip of paper. The regular movement of the paper allows the distance between the pen movements to record the time between phases of the cardiac cycle. 3 of the electrodes are bipolar leads. They measure voltage difference between both arms or between one arm and one leg. 9 of the electrodes are unipolar leads. The total of 12 leads provide a complete picture of the electrical activity of the heart. A normal electrocardiographic pattern includes several waves or deflections during each cardiac cycle. In between, muscle fibers remain polarized and the pen does not move except for indicating the baseline reading. Now we'll see ECG graph and commonly measured components. Each small box represents 0.04 seconds on the horizontal axis and 1 mm or 0.1 millivolt on the vertical axis. The ECG is composed of waveforms including the P wave, the QRS complex, the T wave and possibly a U wave, and of segments and intervals including the PR interval, the ST segment and the QT interval. As the SA node triggers an impulse, the atrial fibers depolarize to produce a recordable electrical change. The first pen movement produces a P wave that shows the depolarization of the atrial fibers leading to atrial contraction. The P wave represents the electrical impulse starting in the SA node and spreading through the atria. The P wave is the first positive deflection and represents atrial depolarization or atrial contraction. The normal amplitude of the P wave is 3 mm or less. The normal duration of the P wave is 0.04 to 0.11 second. P waves that exceed these measurements are considered to deviate from normal. As the impulse reaches ventricular fibers, they quickly depolarize, showing a greater electrical change because of the thicker ventricular walls. When the change ends, the resulting mark is called the QRS complex, consisting of a Q, R and S waves that correspond to the depolarization of ventricular fibers before ventricular contraction. The QRS complex has an intricate shape because there is a constant change in the paths of depolarization waves through the ventricular walls. Atrial repolarization or relaxation occurs during the QRS complex but cannot be seen. The QRS complex contains separate waves and segments which should be evaluated separately. The QRS complex is normally less than 0.12 seconds in duration. The Q wave is the first negative deflection after the P wave. The Q wave or first downward stroke after the P wave is usually less than 3 mm in depth. A Q wave with significant deflection is not normally present in the healthy heart. A pathologic Q wave usually indicates a completed MI. The Q wave is normally less than 0.04 seconds in duration and less than 25% of the R wave amplitude. The R wave is the first positive deflection after the P wave, normally 5 to 10 mm in height. Increases and decreases in amplitude become significant in certain disease states. Ventricular hypertrophy produces very high R wave because the hypertrophied muscle requires a stronger electrical current to depolarize. The S wave is the negative deflection after the R wave. As the ventricles repolarize, a T wave is produced and recorded. Atrial repolarization is missing from the pattern because atrial fibers repolarize at the same time the ventricular fibers are depolarizing. The T wave lasts about 0.16 seconds because repolarization is slower than depolarization. The T wave appears more spread out with a lower amplitude height than the QRS complex. It is often obscured by the larger QRS wave being recorded simultaneously. The T wave represents ventricular repolarization when the cells regain a negative charge, also called the resting state. It follows the QRS complex and is usually the same direction or deflection as the QRS complex. Atrial repolarization also occurs but is not visible on the ECG because it occurs at the same time as ventricular depolarization, that is the QRS. The T wave follows the S wave and is joined to the QRS complex by the ST segment. The ST segment represents ventricular repolarization or relaxation, the point that represents the end of the QRS complex, and the beginning of the ST segment is known as the J point. The T wave represents the repolarization of myocardial fibers or provides the resting state of myocardial work. The T wave should always be present. Normally, the T wave should not exceed a 5 mm amplitude in all leads except the precordial V1 to V6 leads, where it may be as high as 10 mm. The T wave represents the return of ions to the appropriate side of the cell membrane. This signifies relaxation of the muscle fibers and is referred to as repolarization of the ventricles. Electrocardiographic patterns are used to assess the heart's conduction of impulses. The PQ interval is the time period between the P wave and the QRS complex and can indicate impulse transmission times between the SA node and AV node to indicate ischemia or other conditions that affect the AV conduction pathways. Damage to the AV bundle can extend the QRS complex, showing a different recording on an ECG. The PQ interval takes about 0.16 seconds and is also referred to as the PR interval if the Q portion is not visible. The PR interval represents the time it takes for the electrical impulse to travel from the SA node to AV node and down the bundle of His to the right and left bundle branches. The PR interval includes atrial depolarization, contraction, and the passage of the depolarization wave through the remainder of the conduction system. The PR interval is measured from the upstroke of the P wave to the QR junction, represents the time needed for sinus node stimulation, atrial depolarization, and conduction through the AV node before ventricular depolarization, and is normally between 0.12 and 0.20 seconds. There is a built-in delay in time at the AV node to allow for adequate ventricular filling to maintain normal stroke volume. The PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. The QR complex is measured from the beginning of the Q wave to the end of S wave. The QT interval is measured from the beginning of the Q wave to the end of the T wave, and the TP interval is measured from the end of the T wave to the beginning of the next P wave. The ST segment begins at the end of the S wave, the first negative deflection after the R wave, and terminates at the upstroke of the T wave. The ST segment, which represents early ventricular repolarization. The beginning of the ST segment is usually identified by a change in the thickness or angle of the terminal portion of the QRS complex. The end of the ST segment may be more difficult to identify because it merges into the T wave. The ST segment is normally isoelectric. It is analyzed to identify whether it is above or below the isoelectric line, which may be, among other signs and symptoms, or a sign of cardiac ischemia. The ST segment occurs when the action potentials of the ventricular myocytes are in their protophases. At this time, all the ventricular myocardium is depolarized. The QT interval is the time between the Q wave and the T wave. It represents ventricular depolarization, that is contraction, and repolarization, that is relaxation, is measured from the beginning of the QRS complex to the end of the T wave. The QT interval varies with heart rate, gender, and age. Therefore, the measured interval needs to be corrected for these variables through specific calculations. The QT interval lasts about 0.38 seconds. It is the period from the start of ventricular depolarization through ventricular repolarization. The QTC may be automatically calculated by the ECG technology, or it may manually calculate or use a resource that contains a chart of these calculations. The QT interval is usually 0.32 to 0.40 seconds in duration if the heart rate is 65 to 95 beats per minute. Many medications commonly given in the hospital can cause prolongation of the QT interval, that is QTC, placing the patient at risk for a lethal ventricular dysarrhythmia called Torsade points. The U wave is thought to represent repolarization of the Purkinje fibers. Although this wave is rare, it sometimes appears in patients with hypokalemia, that is low potassium level, hypertension, or heart disease. If present, the U wave follows the T wave and is usually smaller than the P wave. If larger in amplitude, it may be mistaken for an extra P wave. The TP interval is measured from the end of the T wave to the beginning of the next P wave, that is also called an isoelectric period. When no electrical activity is detected, the line on the graph remains flat. This is called the isoelectric line. The ST segment is compared with the TP interval to detect ST segment changes. The PR segment is sometimes used to determine the isoelectric line. However, sometimes it is altered due to ischemic conditions. The TP interval is the preferred reference for the isoelectric line. The PP interval is measured from the beginning of one P wave to the beginning of the next P wave. The PP interval is used to determine atrial rate and rhythm. The RR interval is measured from one QRS complex to the next QRS complex. The RR interval is used to determine ventricular rate and rhythm. Now let us see how to determine heart rate from the electrocardiogram. Heart rate can be obtained from the ECG rhythm strip by several methods. A 1-minute rhythm strip contains 300 large boxes and 1500 small boxes. Therefore, an easy and accurate method of determining heart rate with a regular rhythm is to count the number of small boxes within an RR interval and divide 1500 by that number. If, for example, there are 10 small boxes between two R waves, the heart rate is 1500 divided by 10, that is 150 beats per minute. If there are 25 small boxes, the heart rate is 1500 divided by 25, that is 60 beats per minute. We can thus calculate heart rate by dividing 300 by the number of large squares between each RR interval. Heart rate is equal to 300 divided by the number of large squares. For example, if there is one large square between R waves, the heart rate is 300 beats per minute. If there are two large squares, the heart rate will be 150 beats per minute. An alternative but less accurate method for estimating heart rate, which is usually used when the rhythm is irregular, is to count the number of RR intervals in 6 seconds and multiply that number by 10. Number of RR intervals in 6 seconds into 10. The top of the ECG paper is usually marked at 3-second intervals, which is 15 large boxes horizontally. The RR intervals are counted rather than QRS complexes because a computed heart rate based on the latter might be inaccurately high. The same methods may be used for determining atrial rate using the PP interval instead of the RR interval. Diagnostic tests and procedures of cardiovascular system. In this, first we will cover cardiac enzymes or cardiac biomarkers. What are cardiac enzymes or cardiac biomarkers? When heart experiences damage or stress due to lack of oxygen, it releases a substance called cardiac enzymes into the bloodstream. Enzymes are proteins that help our body manage metabolism and other chemical processes. Enzymes perform specialized functions like blood clotting, brain, spine and nerve function. It helps breathing, it helps digestion, musculoskeletal movements. It helps removing waste from our body through urination. Cardiac enzyme marker test is a blood test to measure specific biological markers in the blood. High levels of cardiac enzymes can be a sign of a heart attack or another heart problem. Cardiac enzymes are also called cardiac biomarkers. Where do we get a cardiac enzyme marker test? A cardiac enzyme marker test requires a blood draw. The blood draw takes just a few minutes. In an emergency situation, the blood draw takes place in the emergency department or hospital. For non-urgent situations, the test may take place at healthcare provider's office or a blood testing lab. Who needs a cardiac enzyme test? The healthcare provider may order a cardiac enzyme test if anyone has symptoms of a possible heart problem. These symptoms include chest pain, dizziness, nausea, profuse sweating, shortness of breath. In such patients, cardiac enzyme test is to be done. How the test helps healthcare providers. Cardiac biomarkers help healthcare providers know if symptoms are due to a heart attack, that is myocardial infarction, or angina, or heart failure, or another heart problem. Increase in cardiac enzymes can also indicate acute coronary syndrome or myocardial ischemia. Treatments for these conditions vary. An accurate diagnosis is critical to ensure to receive the appropriate care. What's the purpose of cardiac biomarkers? Healthcare providers measure cardiac marker levels to screen for heart damage and other problems. to diagnose heart conditions that cause symptoms such as chest pain, angina, and shortness of breath, to monitor how well heart medications and heart surgery work, to treat heart conditions like acute coronary syndrome, coronary artery disease, and atherosclerosis. Elevated levels of cardiac enzymes in the blood are a sign of heart damage, stress, or inflammation. Our heart releases these proteins after a heart attack. Heart may also release cardiac biomarkers when low oxygen levels cause the heart to work harder than usual. An enzyme marker test measures heart enzymes, cardiovascular function, and disease are evaluated by blood tests that indirectly monitor heart function and structural damage. What are the types of cardiac enzymes? There are different types of cardiac biomarkers. All of them are either enzymes or proteins. Elevated heart enzymes may show that the patient have cardiovascular disease or other heart problems. When myocardial tissue is damaged, for example because of myocardial infarction, cellular injury results in the release of intracellular enzymes and proteins, that is, cardiac enzymes, isoenzymes, and biochemical markers into the bloodstream, which in turn causes elevated peripheral blood enzyme levels. The first cardiac marker test is troponin test. Because the heart is the only organ that makes troponin, a biomarker test for this enzyme is a primary test healthcare providers use to detect heart damage from a heart attack or ACS, acute coronary syndrome. Troponin levels can rise for up to 12 hours after a heart attack. They stay elevated for up to 2 weeks. Troponin complex 6, located on the thin filament of the contractile apparatus or striated and skeletal muscle and consists of 3 subunits, is composed of 3 proteins. They are troponin C, troponin T, troponin I. These are the most sensitive and specific tests for myocardial damage. In the presence of myocardial damage, the troponin complex on the myofibril breaks down and the subunits of troponin are slowly released into the bloodstream. Troponin is released during myocardial infarction from the systolic pool of the myocytes. Its subsequent release is prolonged with degradation of actin and myosin filaments. Isoforms of the protein T and I are specific to myocardium. Differential diagnosis of troponin elevation includes acute infarction, severe pulmonary embolism causing acute right heart overload, heart failure, myocarditis. Troponins can also calculate infarct size, but the peak must be measured in the 3rd day. After myocyte injury, troponin is released in 2 to 4 hours and persists for up to 7 days. Normal values of troponin I are less than 0.3 Ng per ml and troponin T less than 0.2 Ng per ml. In patients with non-severe asymptomatic aortic valve stenosis and no overt coronary artery disease, the increased troponin T, that is above 14 Ng per ml, was found associated with an increased 5-year event rate of ischemic cardiac events, that is myocardial infarction, percutaneous coronary intervention, or coronary artery bypass surgery. High sensitivity troponin test. High sensitivity troponin testing detects troponins at much lower concentrations and as early as 60 to 90 minutes after myocardial cell injury. Also detects circulating troponins in stable CAD, coronary artery disease, in the absence of myocardial necrosis. Normal values are low, less than 14 Ng per liter for women and less than 22 Ng per liter for men. After the initial blood sample, blood is collected at 12 hours, then daily for 3 to 5 days. Next is creatine kinase. Creatine kinase has a 98% sensitivity for acute myocardial infarction 72 hours after infarction. CK is a catalyst for energy production and is found in the brain, myocardium, and skeletal muscle. CK is sensitive but not specific for myocardial injury. CK isoenzymes are more specific than CK. 3 CK isoenzymes have been identified: CKMM, CKMP, CKBB, with only CKMP is related to the heart. The specific of CKMP is greater than 85% and in some cases as high as 100%, but false positives do occur. Increased levels of CKMP is highly indicative of myocardial infarction. Serum levels increases within 3 to 6 hours after myocardial infarction. Peak after 12 to 24 hours. Normalize within 48 hours. It is relatively specific when skeletal muscle damage is not present. The CKMP isoform of creatine kinase is expressed in heart muscle. It resides in the cytosol and facilitates movements of high energy phosphates into and out of mitochondria. Since it has a short duration, it cannot be used for late diagnosis of acute myocardial infarction, but can be used to suggest infarct extension if levels rise again. This is usually back to normal within 2 to 3 days. Normal range is 2 to 6 Ng per ml. Next is myoglobin. Myoglobin is a small oxygen-binding protein found in cardiac and skeletal muscles and is rapidly released into the bloodstream. Myoglobin is sensitive very earlier after injury, but has poor sensitivity over time and can generate many false positive results. When myoglobin levels are assessed with CKMP results, sensitivity increases as high as 96%, but specificity can drop to as low as 81%. Myoglobin is directly related to muscle mass and is affected by age. Levels increase with age. Race: blacks have higher levels. Gender: women have higher levels. And physical activity: myoglobins can be elevated in the presence of reinfarction, skeletal muscle or neuromuscular disorders, trauma, severe burns, electrical shock, alcohol withdrawal delirium, metabolic disorders, systemic lupus erythematosus, strenuous exercise, renal failure, IM injections, cardiac bypass surgery, seizures, and heart failure. The level rises within 2 hours after cell death, with a rapid decline in the level after 7 hours. However, it is not cardiac specific. Myoglobin is used less than the other markers. Next is homocysteine. Homocysteine is a toxic byproduct of the metabolism of amino acid methionine into cysteine. Homocysteine exerts a direct cytotoxic effect on the endothelium of blood vessels by blocking the production of nitrous oxide, resulting in decreased pliability of vessels and development of atherosclerotic plaque. Increased homocysteine levels ultimately result in atherosclerosis, CAD, MI, stroke, thromboembolism, and peripheral vascular disease. Hyperhomocysteinemia is related to gender, advanced age, smoking, hypertension, elevated cholesterol, decreased folate, decreased levels of vitamin B6 and B12, and lack of exercise. Homocysteine can also be elevated in the presence of other disease, drug use, and caffeine intake. Normal value is 4.5 to 11.9 mcmol per liter, and it depends upon age and gender. Next is B-type natriuretic peptide, BNP. It is synthesized in the ventricular myocardium and released as a response. BNP is released in response to atrial and ventricular stretch. It serves as a marker for heart failure. The most important use of natriuretic peptides is in helping to establish the diagnosis of heart failure in a patient in the urgent care setting in whom the diagnosis is uncertain. BNP is used for diagnosis and prognosis of suspected heart failure. Plasma levels of BNP increase in the presence of left ventricular systolic and diastolic dysfunction, particularly in the presence of decompensating heart failure. An increased BNP level identifies patients at the highest risk of developing sudden cardiac death and those who are in need of heart transplant. It is also associated with heart failure readmissions. BNP is considered as a useful marker of myocardial infarction and is used to guide therapy. BNP levels should be less than 100 ng per ml. The higher the level, the more severe the heart failure. Pro-brain natriuretic peptide. This is increased in patients with heart failure. It has been approved as a marker for acute congestive heart failure. N-terminal pro-brain natriuretic peptide is an inactivated peptide that tends to circulate longer and can detect earlier forms of heart failure. Both tests show similar information, although the absolute values of NT-pro-BNP are about 5 to 10 times higher than BNP. With more data, the value of NT-pro-BNP is higher than BNP for treatment, monitoring, and managing heart failure patients. The reference values of BNP and NT-pro-BNP are different to exclude or confirm a diagnosis of heart failure. These values also depend on age and gender and are higher in elderly persons and women. Normal findings are as follows. BNP is less than 100 ng per ml. NT-pro-BNP is less than 300 ng per ml. If the BNP is more than 400 ng per ml is indicative of heart failure. Next is C-reactive protein. It is an inflammatory marker that may be an important risk factor for atherosclerosis and ischemic heart diseases. CRP is produced by the liver in response to systemic cytokinesis. Elevated CRP is associated with AMI, stroke, and progression of peripheral vascular disease. However, it can also be elevated with any inflammatory process. In addition to revealing events associated with CAD, CRP can also be used to identify patients at risk for developing CAD. Patient is having less than 1 mg per dl is having lowest risk. If the patient is having 1 to 3 mg per dl is having moderate risk, and the patient with more than 3 mg is having highest risk. Next is highly sensitive C-reactive protein. It detects an inflammatory process such as that associated with the development of atherothrombosis. A level less than 1 mg per L is considered low risk, and a level greater than 3 mg per L places the client at high risk for heart disease. Next is copeptin. Copeptin is a stable surrogate marker of vasopressin. The concentration of copeptin in the blood circulation ranges from 1 to 12 pmol per liter in healthy individuals. The levels of copeptin are slightly higher in men than in women and are not influenced by age. Increased levels highly indicative of MI, higher in men after exercise and with stress, influenced by fasting and water load. Copeptin is a diagnostic and prognostic biomarker in CVD, including the rapid rule-out of acute myocardial infarction, mortality prediction in heart failure, and stroke. Next is factor I or fibrinogen. It is directly linked to increased cardiovascular risk. It is involved in the coagulation cascade, that is converting fibrinogen to fibrin by thrombin, stimulates smooth muscle cell migration and proliferation, and promotes platelet aggregation, which increases blood viscosity. Next is D-dimer. It may be done to evaluate for aortic dissection when chest pain is present. It is a degradation product of cross-linked fibrin and reflects activation of extrinsic pathway of the coagulation cascade by tissue factor exposed in the aortic media by the intimal tear. It is also used to evaluate for the presence of thrombus or embolus. Next is glycogen phosphorylase isoenzyme BB. Glycogen phosphorylase isoenzyme BB is one of the 3 isoforms of glycogen phosphorylase. This isoform of the enzyme is in cardiac and brain tissue. Because of the blood-brain barrier, GPBB can be seen as specific to heart muscle. GPBB is one of the new cardiac markers which are considered to improve early diagnosis in acute coronary syndrome. During the process of ischemia, GPBB is converted into a soluble form and is released into the blood. A rapid rise in blood levels can be seen in myocardial infarction and unstable angina. GPPB is elevated 1 to 3 hours after process of ischemia. Next is ischemia modified albumin. IMA can be a sign of myocardial ischemia. This blood flow problem in our heart can occur due to coronary artery disease or coronary spasm. Healthcare providers usually order an IMA test along with an electrocardiogram to confirm or rule out ACS. Now let us see what are the other tests used to diagnose a heart attack or heart damage. Complete blood count. The red blood cell count decreases in rheumatic heart disease and infective endocarditis and increases in conditions characterized by inadequate tissue oxygenation. The white blood cell count increases in infectious and inflammatory diseases of the heart and after MI because large number of white blood cells are needed to dispose of the necrotic tissue resulting from the infection. An elevated hematocrit level can reflect vascular volume depletion. Decreases in hemoglobin and hematocrit levels can indicate anemia. Blood gas tests to measure oxygen, carbon dioxide, and acid levels. Blood coagulation factors. An increase in coagulation factors can occur during and after MI, placing the client at greater risk for thrombophlebitis and formation of clots in the coronary arteries. Serum lipids. The lipid profile measures serum cholesterol, triglyceride, and lipoprotein levels. The lipid profile is used to assess the risk of developing coronary artery disease. LDH, lactate dehydrogenase. LDH is not as specific as troponin. Approximate peak is 72 hours. LDH catalyzes the conversion of a pyruvate to lactate. LDH1 isozyme is normally found in the heart muscle and LDH2 is found predominantly in blood serum. A high LDH1 level to LDH2 suggests MI. LDH levels are also high in tissue breakdown or hemolysis. It can mean cancer, meningitis, encephalitis or HIV. Lipoprotein A is a molecule. This is similar to low density lipoprotein cholesterol. Lipoprotein A or LPA is a modified form of low density lipoprotein LDL. It increases cholesterol deposits in the arterial wall, enhances oxidation of LDL-C, and inhibits fibrinolysis, resulting in the formation of atherosclerotic plaques and thrombosis. Treatment of elevated lipoprotein A is suggested only for patients with a history of premature vascular disease without other risk factors. Next is microalbuminuria. A small amount of protein in the urine has been a marker for endothelial dysfunction in cardiovascular disease. Now let us see electrolytes. Potassium. Hypokalemia causes increased cardiac electrical instability, ventricular dysarrhythmias, and increased risk of digoxin toxicity. In hypokalemia, the ECG shows flattening and inversion of the T wave and appearance of a U wave and ST depression. Hyperkalemia causes asystole and ventricular dysarrhythmias. In hypokalemia, the ECG may show tall peak T wave, widening QRS complexes, prolonged PR intervals, and flat P waves. Sodium level. The serum sodium level decreases with the use of diuretics. The serum sodium level decreases in heart failure, indicating water excess. Calcium. Hypocalcemia can cause ventricular dysarrhythmias, prolonged ST and QT intervals, and cardiac arrest. Hypercalcemia can cause a shortened ST segment and widened T wave, atrioventricular block, tachycardia or bradycardia, digitalis hypersensitivity, and cardiac arrest. phosphorus levels should be interpreted with calcium levels because the kidney retain or excrete them in an inverse relationship. Magnesium. A low magnesium level can cause ventricular tachycardia and fibrillation. Electrocardiographic changes that may be observed with hypomagnesemia include tall T wave and depressed ST segments. A high magnesium level can cause muscle weakness, hypotension, and bradycardia. Electrocardiographic changes that may be observed with hypermagnesemia include a prolonged PR interval and widened QRS complex. Electrolyte and mineral imbalances can cause cardiac electrical instability that can result in life-threatening dysarrhythmias. Blood urea nitrogen. The blood urea nitrogen level is elevated in heart disorders such as heart failure and cardiogenic shock that reduce renal circulation. Next is blood glucose. An acute cardiac episode can elevate the blood glucose level. In addition to lab tests, chest X-ray, echocardiogram such as transesophageal echocardiogram, electrocardiogram, exercise stress test, or nuclear cardiac stress test, angiogram, positron emission tomography scan can be done to the patient to rule out cardiac problems.